Good evening, everybody. Uh, Thank you very much for joining on time, but it was technical problem. I could not join in time in the link, though I was trying very hard. But today we are going to learn ovarian stimulation protocols in IVF, and I think that is a very important topic because, as we know, we are coming up with all the IVF centers, and I think fine tuning of IVF protocols, that is something we should be really, really good so that we don't land up in any troubleshooting which happens usually during IVF stimulation protocol. Friends, we know that we are here to add what we can to the life, not to get what we can from the life. So it is like we want to add into the life. All this knowledge is a value added thing. So we know that in IVF, when we say ovarian stimulation, it is controlled ovarian hyperstimulation, but this is a typical word. We use it more often in IUI, but it is something like it's a regulated superovulation by turning off the patient's own hormones followed by stimulation. And aim is to have a multiple follicles growth, okay, and also at the same time control the timing of ovulation so that we can retrieve the oocytes before they get ovulated inside the body. And the third aim is to prevention of premature LH surge, because we know that if there is a premature LH surge, it will lead to progesterone production and it will advance the endometrium phase. So we will not be able to do a fresh transfer if at all we have planned. So we must keep it in mind. And for that matter, we have already understood the different strategies of down regulation. I think 3 weeks back, which the lecture which I took, down regulation of pituitary gland, that is related to prevention of premature LH surge. Now, we have three principles. Okay, one is to get adequate number of good quality oocytes, and of course this adequate number is 8 to 15. But nowadays, even if we get more than 15, we are more than happy, because it will allow us to have a more cumulative live birth rate or cumulative clinical pregnancy rate. But the only challenge we face is when we get less than 8 oocytes, so maybe 3, 4, 5, 6, because we know these number of oocytes which are retrieved, especially in patient who's got a low reserve, they also have a problem with the quality of the oocytes, and that's why these numbers are matters when it comes to low reserve patients. Second principle is to prevent premature LH surge, which I'm not going to talk more in this lecture because we have already done this about all GnRH agonist antagonist protocol, but we'll just going to brush up. Third is to prevent ovarian hyperstimulation syndrome. So how we can prevent that, that also we are going to cover it. Okay. Now, three parts when it comes to protocols. One is stimulate the ovaries with the help of gonadotropins. Second, you downregulate the pituitary. Either most commonly it is done with the GnRH antagonist, or it can be done with a GnRH agonist. Third is a third agent which is used nowadays is a progesterone. That also we're going to touch upon. Third part of the protocol is a ovulation trigger. That actually causes final maturation. So only two options we have. Either we give SCG from outside or we give GnRH agonist so that there is an endogenous LS release which will mature the oocyte. Now this is a simple protocol or a simple physiology. The first picture what you see, I hope you see my okay. All right. So I don't know whether I can show you laser pointer. Yeah. So as you can see in my particular picture here, in a natural cycle on the second day, the FSH level is between 5 to 7. And this level goes high in response to low estrogen on the first and second day. And on second, third, fourth day, this FSH goes beyond this threshold line. Because of increasing FSH beyond threshold, we get 1, 2, 3 follicles selected or recruitment. Then these follicles will start producing estrogen. And estrogen, we know that once the estrogen increases, it will reduce the FSH, where it goes below the threshold by 6th or 7th day. And that's where the out of 3 or 4 recruited follicles, 2 or 3 follicles will go into atresia, and only one dominant follicle will go and grow. So that's why in spontaneous cycle, we get monofollicular growth. We use the same principle. This is FSH window. So we are going to keep this FSH window wider, because of which multiple follicles will grow. So what we do on the second day in IVF cycle is we give FSH in a dosage beyond 225. So 225, 300, 375, 450 of HMG. So if you are giving that high dose, there is within 24 hours, the level of FSH goes very high. Now, the more higher the FSH level on second and third day, the more number of follicles will recruited. Now, in IVF, we give daily injections of HMG or FSH. So we don't allow FSH to go down even if your follicles produce estrogen, because there is a daily FSH given. Remember that, that's very important. So the FSH window is no more window. It is only has a ceiling which is kept like that for over 8 to 10 days till you get a desired size of the follicle. So this is what is called a concept. Now important, how better you take the FSH level above the threshold, you will have a that many number of follicles. Now this is very important. I'll give you one example. If you are doing a ovarian stimulation protocol for 28 years old lady, her antral follicular count is 10, 10 on each side. Now what happens if you start for such patient 150 of HMG on second day? See, she has 10, 10 follicles, but 150 HMG will just take I mean, FSH level little ahead of threshold, because of which there might be 3 follicles on the right and 3 follicles on the left. So she has a capacity of recruiting more number of follicles. But because your initiating dose is 150, the FSH level don't go so high on second, third day. So your less number of follicles are recruited. So please remember, your starting dose is very, very important. And this is how I always feel that you should remember. So the best, you can, two parameters you can judge. One is the antral follicular count and second is the AMH. You can note it down. If you see a normal responders, that is 8 to 10 follicles on each side, so the antral follicle count is around 16 to 20. So the best starting dose for normal responders is HMG 300 or maximum 375. Okay, there is no need to give 450. 300 to 375 is more than enough. Okay. Now suppose these numbers are more, instead of 16, 20, antral follicular count is between 20 to 30. Here 375 is something, I'm sorry, 300 is something which I will recommend. Don't go beyond 300. So what happens in 14, 15 on each side, that becomes 28, 30 antral follicular count. So 300 is maximum you can give. Even if you start 225, I will say okay, because you can always step up the dose later. So you recruit and increase the dose. So 225 to 300 is something for antral follicular count between 20 to 30. Now in hyper responders, when you have more follicles like 18 to 20 or 20, 22 on each side, so now your antral follicular count on each side is somewhere close to, antral follicular count is somewhere above 30, that is 30 to 45. Now in this group of patient, you will only go with a 150 HMG dose, because otherwise you will get 50, 60 oocytes. So remember, according to the number of antral follicles, you can decide the dose. Okay. For patient who's got a lower response, that is below 8 antral follicles, all of them you can go safely with HMG 450. Okay. So this you remember. Now, as I said, 450, 300, 150. When it comes to recombinant FSH, how should we you decide the dose? If you want to use recombinant FSH, whenever you want to use 300 HMG, better to use recombinant 200. So HMG 300 is equal to 200 of recombinant FSH. So you will get a similar effect if you want to use recombinant FSH. If you want to use HMG 150, the recombinant dose should be only 100 IU. Don't go beyond that. And if you want to use HMG 450, that is equal to recombinant FSH of 300 IU. So all poor responders, poor reso patient, you can use recombinant FSH 300. That will give a similar response like HMG 450. I hope you are clear. Okay, we may discuss it at the end of the lecture if you have any query. But please note it down. This is how you will select your dose, because suppose even if you by mistake select more than required, so there is a possibility that you may have a over response. But in that case, you do not worry, because in that case what you can do is that you can do a freeze all cycle by giving GnRH agonist trigger. So there is a safety margin now available. You will not land up in a OHSS in this era now. Coming to IVF stimulation protocols. Now, this protocol, first thing, keep it in mind how you will do the fresh embryo transfer in GnRH antagonist protocol. So this is typically happens in a 100% all poor responders patient where you'd like to do a fresh transfer, and those normal responders where estrogen levels are below 2000, means somewhere around 9, 10, 11, 12 antral follicles you are getting. So in antagonist protocol, we start with HMG recombinant FSH. As I said, if it is a normal responders, 300 is more than sufficient of HMG, and 200 of recombinant FSH is more than sufficient. So you give for 4 days. On the second day of period, third day of period, fourth day of period, and fifth day of period. You call on fifth day of stimulation patient back to the clinic, and you assess the recruitment. So how many follicles have been recruited from total available follicles? Okay, that idea you will get here. So here, if it is a fixed antagonist protocol, you will add cetrorelix 0.25 micrograms subcutaneously from on this fifth day of stimulation. Now you do have a choice that you can, instead of fifth day, you can start on sixth day. Okay, that's again a called fixed day protocol, because you are sure that fixed day you are going to start antagonist. There is another protocol which is flexible, which we have already discussed in previous lecture, where you will wait till follicles become 14. So maybe on seventh day or eighth day they will become 14, and then you will start cetrorelix. So this is how then you will continue giving antagonist along with HMG till the day your follicles are ready. What is the best size? You need to understand your maximum largest size follicles are have to be around 19 to 20 size, at least beyond 19. And your second crop, out of second crop, majority of your follicles has to be between 15 to 18. So if you have this picture, then you can decide trigger, and here you can give SCG along with plus minus GnRH agonist, so dual trigger. We will discuss that. 35 hours later, you are going to do a oocyte retrieval. So according to your oocyte retrieval time, you will go retrospectively back and ask and calculate the time of trigger. Once oocyte retrieval done, you will do the ICSI on the same day, and then 5 days of culture for the embryo till you get a blastocyst, and you will transfer the embryo on fifth day, 5 days from the oocyte retrieval. And from the embryo transfer, 13 days later, if it is a blastocyst transfer, then suppose for example 15th August you have done an embryo transfer, 13 days later means 28 August you will do the beta SCG 13 दिन के बाद. Okay, suppose if it is a day 3 embryo transfer, that is 2 days prior than blastocyst transfer, so your beta SCG time will be 15 days later. Okay, so clear about this. Now next protocol is again similar, but this time it is specifically for hyper responders where you want to freeze all the embryo. So the all protocols is same till the day of trigger, but on the day of trigger you will only give GnRH agonist, and the dose, please write it down, the dose which you will use compulsory as a trigger in case of freeze all strategy. If you are using luprolide, it is 2 milligram. If you are using decapeptyl, then it is 2 pre-filled syringes, that is 0.2 milligram. Okay, minimum you have to give this dose. Okay, there are some studies which has compared whether luprolide 2 or 3 milligram has an advantage. So those studies do not say that giving 3 milligram has got any advantage. So 2 milligram of luprolide is sufficient as an agonist trigger. If it is SCG, then it is, I'm sorry, if it is decapeptyl, then 0.2 milligram. So 2 prefilled syringe, because 1 prefilled syringe contains 0.1 milligram. So another question is that when shall we plan a antagonist dose in these protocols? That is another confusion everybody has got. Now remember, cetrorelix has got 30 hours plasma half-life. So remember, so how you can plan retrospectively. So for example, suppose you want to save a GnRH antagonist, one injection. What you can do, you know that your trigger will be in the night, so that you can do the pickup on the in the morning after 35 hours. So your night injection might be say example it is at 10 o'clock. Okay, so if you keep 10 o'clock as an antagonist right from fifth day, so the one day prior on eighth day you have given a 10 o'clock antagonist. Ninth day, you have done a scan, follicles are ready, and you are going to give a trigger at 10 o'clock in the night. So your one injection is saved. Okay. Your one injection is saved because that eighth day, 10 o'clock injection will have an effect till ninth night. Okay. Now suppose if your injection is in the morning hours, for example, you are asking a patient to take the injection at 10 a.m. antagonist. So what happens? When you have given on eighth day, that is one day prior to your trigger day, if your injection is given at 10 a.m., the action of antagonist will remain till ninth 10 a.m. So from 10 a.m. till night 10 p.m., 12 hours, you will not have any antagonist action. So there is a possibility of LS surge. And that's why it is important that either you plan the injection is in the late night, maybe I do in my practice, I give it at 8 o'clock. So that is more convenient so that I can give a trigger. So I hope you understood my point. Okay, there used to be a principle that at least minimum 8 to 9 hours time interval we should keep it between last antagonist dose and the trigger, which is completely false. It's not required. At least 24 hours. If you have more than 24 hours time interval between last antagonist and trigger, you must repeat on the day of trigger. So remember that. Okay, so we have understood flexible and fixed day protocol. Fixed is on day 5, day 6. Flexible when the follicles reach more than 14. Now, you will ask me questions, sir, what is best protocol, flexible or fixed? I feel there is no difference. It is as effective as your conventional. So you can use either of the protocol. There is no problem. There is little advantage of flexible protocol that there is a total consumption of recombinant FSH doses is significantly reduced if you are using a flexible protocol. So you can use a flexible protocol. Next is GnRH agonist long protocol. This is typically you use it in poor responders when you have seen asynchronous follicular growth, or there is a documentation of poor ovarian response to your ovarian stimulation by poor responder. So here you can use GnRH agonist. We have understood this in two lectures. During down regulation lecture, that day 21 of the cycle, we will ask a patient to take a leuprolide acetate 0.5 milligram daily, which in insulin syringe equals to 20 units, and daily she will take in the morning between 7 to 9 a.m. Give it for 10 to 11 days, and you do expect at the end of 30 or 31 days of her period, she will get her next menses. But in case if a patient is anovulatory, you will have to add here on day 23 progesterone for 5 days. So that day 23 to day 27, you have given a progesterone. You have asked her to stop from day 28. So 3 or 4 days later, she will get withdrawal menses. So normally 8 to 10 days are sufficient for agonist to completely downregulate the pituitary. Once she gets her menses, second day, you start the gonadotropins injection. As we discussed the doses, remember your antagonist will continuously go on till the day of trigger. So same 20 units, you don't have to reduce the dose to 10 units. You will continue the same 20 units from second day of menses till the day of trigger. And ahead everything is same. But remember, we have already downregulated pituitary. All GnRH receptors are occupied by agonist. Here you cannot use agonist trigger because the initial first 1 or 2 doses in luteal phase is going to empty the pituitary completely. There will not be any LH secretion in pituitary. Pituitary will be empty. So if you happen to give GnRH agonist as a trigger into this long protocol, you will land up in zero oocytes. So in this protocol, only and only and only SCG. Okay, remember that. Now, there is another protocol. What we understood is a GnRH long protocol. Now GnRH short or flare protocol. So here, what we have done is we have given a oral contraceptive pills for 21 days so that we have downregulated pituitary. We stopped it. Patient has got her menses. From the second day of the menses, we have given GnRH agonist 1 milligram, that is 40 units daily on second, third, and fourth day. So 3 days along with HMG. So whatever desired gonadotropins according to the antral follicular count, we will start, but we will give GnRH agonist 40 units, that is 1 milligram daily from second, third to fourth day. Fifth day onwards, you will reduce that dose to 20 units, that is 0.5 milligram. Now the purpose of 1 milligram is to give a slightly higher doses so that pituitary will release all the FSH and LH, and it will help us to recruit more follicles from because of the endogenous FSH as well as exogenous FSH. So you'll have a better recruitment. This was the concept of GnRH agonist short protocol. Why they say short protocol? Because there are no 11 days injections in previous luteal phase, previous cycle luteal phase from day 21 to first day of menses. That part is absent here. That's why it's called short cycle of agonist. And you will continue agonist daily till the day of trigger. Again, here you cannot give GnRH agonist as a trigger. You have to use SCG. So please remember that. Next protocol is ultra short, means it is still shorter time. So here we are given only for those first 3 days, same dose, 1 milligram of luprolide for 3 days. Fourth and fifth day, we don't give agonist. We just utilize the surge effect. And fourth and fifth day, we don't give anything. And then fifth or sixth day, either you can use a fixed protocol where you will start antagonist 0.25 milligram daily, or you can go for flexible. When the follicle reaches 14 millimeter, then you can start GnRH antagonist. So here it's like agonist plus antagonist, but agonist we have used it for more recruitment by using its pituitary surge effect, and down regulation is by antagonist. So these protocols aims to enhance ovarian response by enhancing the release of early follicles with FSH with no profound inhibition of ovarian response through the ovarian GnRH receptors while sufficiently inhibiting premature LH. So both the things which we have already done in this protocol. Now, there is something called as prolonged GnRH agonist, means you are given it for a very long time. This is used generally in endometriosis. So what happens in endometriosis? You need either you have operated or it's an advanced stage of endometriosis. There is a lot of chronic inflammatory reaction in the pelvic cavity, which can reduce endometrium receptivity and decrease pregnancy rates. So what you do either after the surgery or randomly when you have not done the surgery, on the day 2 of menses, you will give gonadotropins depot injections. Normally, it says that minimum 28 days it will allow the suppression. So every 28 days, you will repeat depot injection. So at least 2 or 3 injection you will give according to the stage of the endometriosis. From the last injection, 20 days later, you will start the stimulation. Okay. So that during those last, because as you remember, 28 days. So last 10 days, you will utilize that agonist down regulation effect and give gonadotropin so that multiple follicles will grow. So this is prolonged GnRH agonist protocol. Again, remember, you have to use SCG in this patient. So even if endometriosis patients sometimes do have a larger number of antral follicles, like they will behave like hyperresponders. So be careful in such patients because you will have no choice than giving SCG. So if she responds too much and there is a OHSS risk, you have no choice than giving SCG, and patient will have OHSS, and you have to manage preventive strategies and therapeutic strategies of OHSS. So be careful. And but this is something very good, used to be good protocol in last decade for severe endometriotic patients. But nowadays, recent ESHRE guidelines in 2023, they say it has got no added advantage in terms of live birth rate. So they have recommended that please don't do this prolonged GnRH agonist protocol. You either go with day 21 long agonist protocol or antagonist protocol in endometriosis patient. So that will be sufficient enough. Now, this is something called as a CARTO protocol. You should know this is not commonly practiced. It is called minimal stimulation protocol. So here the target is you are only having two or three oocytes. Okay. So obviously you will need a lower dosage of gonadotropin. So whole cycle is inexpensive. Usually in poor patients, developing countries, they use this where you will give clomiphene citrate from second day to sixth day. Seventh day onwards, you will give either gonadotropins, either of the gonadotropins in a dose of 150 IU daily till the day of SCG, and you can give a trigger. As I said, mean number of oocytes retrieved usually on 2 to 3 in these patients, and you can do a fresh transfer also because of the lower number of estrogens. But sometimes because it is clomiphene citrate is used, sometimes clomiphene induce anti-estrogenic effect on endometrium. So sometimes you just have to freeze the embryos. Now, this is very important protocol, that is progesterone prime ovarian stimulation. So in PPS protocol, your gonadotropins is same. You start from second day of menses and you will give continuously because you want uniform growth of the recruited follicles. But in progesterone prime ovarian stimulation protocol, it is called PPOS is progesterone prime. So what you do on the second day when you are starting the injection of HMG or recombinant FSH, same day you will ask a patient to take medroxyprogesterone acetate tablet, which is 10 milligram once in a day. Or if you are using a diet, if you want to use dydrogesterone, then the dose has to be 10 milligram BD. So if it is medroxyprogesterone, it is OD, but dydrogesterone, it is BD. And you will start give it from the day of starting the gonadotropin stimulation till the day of trigger. Now in PPOS, remember that you can use agonist as a trigger. There is no problem because there is no down regulation of GnRH agonist. Pituitary um, do have a LH and FSH in the gland. So you can use agonist as a trigger in case of too much response, and you can do a embryo vitrification. But remember, whenever you use a PPS protocol, you cannot do fresh embryo transfer because you have given progesterone during follicular phase. It is going to have an advanced endometrial growth or phase, and it is going to not allow pregnancy to implant, embryo to implant. So all PPS protocol compulsorily embryo vitrification has to be done. Okay, this is a meta-analysis comparing, efficacy of this PPOS. So it clearly says, this is 2021. It clearly says that number of mature eggs, according to that available embryos, optimal embryos, and the rate of cumulative pregnancy in PPS group are all better than those in the control group. And lower serum LH hormone on the day of SCG injection and a lower rate of cycle cancellation in the PPOS group. So your chances of cycle cancellation is very, very low. Now, how does it act? So it has got two advantages. When you use medroxyprogesterone, the metabolite of medroxyprogesterone acetate is androgens. So that help to promote the proliferation of granulosa cells in patients with poor ovarian response. So these androgens are going to stimulate granulosa cells, and it will help us to have a better, embryo, better development of follicles, and also better quality of eggs. Also, in the early follicular phase, when you are giving androgens, when you are giving medroxyprogesterone, when the level of estrogen is low, progesterone reduces the frequency of GnRH pulses, which are actually coming because which are released by hypothalamus by acting on the progesterone nuclear receptors in the hypothalamus. So there are progesterone nuclear receptors in the hypothalamus. So this, when you are giving progesterone in the early follicular phase, the GnRH pulsatility stops. So it reduces the LH levels effectively, blocking the positive feedback effect induced by estrogen and inhibiting the early onset of LH peak. So you don't see those patients having very early premature LH surge on day 4, day 5, and day 6. So PPS has got kind of a little advantage. Now, next protocol is a dual stimulation protocol. In dual stimulation protocol, what we do, you will understand it very, very clearly. Everything is as it is, like a GnRH antagonist. You have started a second day stimulation given for 4 days gonadotropins. Fifth day, along with gonadotropins, you have added GnRH antagonist. Then you have continued HMG or recombinant FSH along with antagonist till the day of trigger. We give only GnRH agonist as a trigger. We do oocyte retrieval, we do ICSI, or we may freeze the oocytes, but generally embryo, oocytes are subjected for fresh ICSI. Then 5 days later, you will do a embryo vitrification. But in dual stimulation, suppose you have done the pickup on Monday, 3 days you will pass, that is Tuesday, Wednesday, Thursday, and Friday you will start the second stimulation. So 3 days later, you will start the gonadotropins again. And similar cycle you will repeat. You'll give for 4 days gonadotropins. Fifth day you will add antagonist, and you will continue the same way. Again, you can give GnRH agonist trigger and do the oocyte retrieval. So what happens, because antral follicular wave comes every 15 days, so you do have some antral follicles appeared by mid-cycle. So you do have certain follicles respond in the luteal phase, and you will still have more number of oocytes. So obviously, why are we doing this when we have no time? This is typically happens in a cancer patients. So you have a short of the time and you need lots of oocytes. So here you can utilize these dual stimulation protocol. Now, also you have two more options. Remember, first part is absolutely going to be same. In the second part, you know that there is a progesterone in the circulation because of the luteal phase. So sometimes you don't need a antagonist to be given. Endogenous progesterone itself will not allow LSH, but in the first stimulation protocol, when we give agonist, it always causes early luteal phase defect, so low progesterone level. Then that's why the little slightly risk is there of premature LH surge, and that's why cetrorelix is as an antagonist should be given in a second luteal phase. Okay. Again, you don't need to use agonist only as a trigger. Depending on the response, you can use a dual trigger also, SCG as well as GnRH agonist. So both options are absolutely okay. Now this is dual stimulation protocol. Now uh, this is I think same. Yeah, it's I think all right. I think it's the same slide that I was emphasizing that on the second part, that instead of antagonists, you can save the expenses by giving medroxyprogesterone right from the first day of the ovarian stimulation in luteal phase. So remember that. So you will save 5 to 6 injections of cetrolic expenses, and you just need 10 tablets of medroxyprogesterone. So that is another thing which you can modify. So friends, it is typically said that whenever you want to do a fertility preservation, especially in cancer patient, you'll go for dual stimulation, or it has been shown that it is a promising approach for patients with a low reserve. So maybe so low that in first stimulation you get two oocytes, second stimulation you get one or two oocytes, and you will have 3 to 4 oocytes available for the fertilization. Now, this was compared, this was a bi-stimulation. Now this is very good study which has given some kind of insight. Can we use this by dual stimulation in poor responders? So 88 women with POR, according to Bolono criteria, they were equally divided into uh, two groups. One group received dual stimulation as we have understood, and 44 is a conventional group where you will do it at a single follicular stimulation. So here they found that cumulative number of mature oocytes and total embryos obtained from both the sides, they are not different between both the groups. Implantation rates were also similar. The cumulative live birth rate was not statistically different comparing control versus duostil group, that is 34 versus 17.9%. So it was higher, but it was not significant. So in poor responder, dual stimulation though feels good, but it has shown that no benefit of dual stimulation, for poor responders. Now there was very interesting concept. Now, as I said, because we are doing follicular and then luteal phase stimulation, we won't be able to do a embryo transfer, that is fresh embryo transfer. So this group thought of that why can't we have stimulation 2 times only, but the first stimulation we will start in a luteal phase, means 18 to 21 days of the menses we will start gonadotropins. Then we either give progesterone or we give antagonist, do the retrieval at the end of 30 days where patient is expecting periods, because she has a progesterone, and once we stop progesterone, 3 days later she'll have withdrawal. So from the last oocyte retrieval, 5 days later, you will, which becomes the next follicular phase of next cycle. There you will start a second stimulation. And this time, on the day of trigger, you will give SCG as a trigger. So you have an advantage of doing a fresh embryo transfer after this second stimulation, which is not the case in that previous diagrammatic representation. So this is they call dual stim fresh, means with dual stimulation you have done a fresh embryo transfer. So they compared this with a single stimulation, and they found that dual stimulation fresh group resulted in a significantly higher number of good quality blastocysts as compared to single stimulation. That was the one, that was their primary outcome actually, whether it gives you better number of blastocysts. Secondary outcomes were whether ongoing pregnancy rate has got any impact. So they found that even if you have gone with this kind of scenario or with a single stimulation of follicular phase, there is no difference in ongoing. So pregnancy outcome is not changing. So really speaking, do we really need to advise our patient to put them under so much burden of expenses by giving two stimulations? Almost double expenses for the lab also. So to be honest, we have to really think about it. Now, how can we prevent? See, now we have understood different protocols. So in poor responders, the one problem which we face in GnRH antagonist protocol is a asynchronous follicular growth. So in this group of patient, what you can do is give a pre-treatment with estrogen. I think this also we have understood in downregulation lecture, where what we can do is we give these patients estrogen 4 milligram per day. You can use estradiol valerate or estradiol hemihydrate, but use a 4 milligram per day. You start from day 20 or day 25. Both options you have. I personally feel day 20 is good because it gives you kind of a good pituitary downregulation for over the time period. And you continue giving, means ask a patient to even take estradiol on the first day of the next menses. And second day, you ask her to stop taking estrogen, and second day you start gonadotropins. Okay, so here you will give antagonist on day 5. That protocol will remain same. What you modification you have done is only pre-treatment estradiol. So what happens, because you are giving estrogen, it will not allow FSH release, which happens in late luteal phase, because of which 2 3 follicles get selected in late luteal phase, and that's why you see a asynchronous follicular growth. So remember, estrogen is something which you can use it in especially poor responders or those patients who have shown a asynchronous follicular growth in previous protocol. Now, which gonadotropins? Because we are talking about ovarian stimulation protocol. So first, we'll discuss about hyper responders, all PCO patients. Shall we use recombinant FSH? Is it better than HMG? So this was a megaset trial in 620 patients, and they said, and they have shown that the OHSS rate is slightly low with HMG, though not significant, and even the incidence of moderate to severe OHSS were more with recombinant FSH, but not lower with HMG. If you look at the ongoing pregnancy rate, because that is what where our interest is, there is no difference between ongoing pregnancy rate between recombinant FSH and HMG. And also, when it comes to early pregnancy loss, it was a difference of 7.7% between miscarriage rate between HMG and recombinant FSH. So HMG has got a lower early pregnancy loss. So they concluded that in all predicted high responders, where whoever will probably give more than 15 oocytes, you use HPHMG or you use recombinant FSH, it will not have impact. Slight advantage of having lower incidence of OHSS with HMG. So you can use HMG highly preferred as an appropriate treatment option. Now, what about, if you, this is a study, like this was a meta-analysis. They wanted to know whether FSH alone is better, or FSH plus LH is better, or HMG is better, or FSH plus SCG is better. So this meta-analysis says, see, if you use FSH, being a recombinant FSH, 98% pure hormone, it always gives a slightly higher oocyte number. So where are we concerned about higher oocyte number? Of course, poor responder. So in my practice, what I felt is that whenever you are handling a young patient and a poor reserve patient, FSH is best. You use FSH. Otherwise, all other patients, hyper responders, normal responders, elderly poor responder, use HMG. because HMG improves collection of mature oocytes more embryos, and it increases the implantation rate. Now, when you will add LH, this meta-analysis says LH addition will lead to higher pregnancy rate, because LH all plays a very important role in a late follicular phase for cytoplasmic maturation. So whenever you see a lower ovarian response on FSH by day 5, especially those young poor responders, you can add LH there. Otherwise, you don't need to add LH right from second day. But this is again the same group, the Poseidon group 1 and 2. These are all young and old patient but good reserve patients. It is said that you should use FSH recombinant than urinary gonadotropins preparation, and you have to use a FSH step-up dose in these patients, and you can use a recombinant LH supplementation alone or combine. That is means FSH alone or FSH plus LH. You can use that. So these different scenarios were compared, where a recombinant addition of recombinant LH has got any impact on results. So they found that it is only beneficial in two scenarios. If you are handling a young patient that is less than 35, having a good reserve, you have started giving her FSH, but on day 5, you see a very low response. All follicles are, they are appearing like 7-8 millimeter, they are not responding, so there you will add recombinant LH, because this patient need LH, and you will see that follicles will quickly get on the track with increasing size. Or elderly woman who has got a low reserve because of the age related low reserve, elderly or poor ovarian reserve patients beyond 36, you will add LH if you are using FSH, or you can simply use HMG here also. So remember that, where to use recombinant LH. Another adjuvant you must remember is letrozole in poor responders. The recent studies says that, you're going to use recombinant FSH or probably HMG, whichever, in antagonist protocol for poor responders. So if you give 5 milligram of letrozole in first 5 days, that is the day when you start gonadotropins, day 2 to day 6, if you add letrozole, and it was compared with a group where antagonist protocol only but without any letrozole. So addition of letrozole is associated with higher number of oocytes, higher number of M2 oocytes, and FSH requirement goes down, duration of stimulation goes down, and without, there is no compromise in the clinical pregnancy rate. So I think addition of letrozole, especially this is another systematic review, especially in all patients, they feel that in poor responders and normal responders, if you add letrozole in the first 5 days of stimulation, it will definitely reduce the gonadotropins consumption, and your live birth rate and number of oocytes will be more with addition of letrozole. But in higher responders, there is no effect on reproductive outcomes. So in higher responder, please don't use letrozole. Last point is ovulation trigger in hyperresponders. I told you all hyperresponders will go for a freeze all strategy, freeze all embryo strategy, and frozen embryo transfer. So you will give only GnRH agonist as a trigger. You will not give SCG, because you don't want to have a OHSS or ovarian hyperstimulation. In normal responders, preferably you look at the E2 level, look at the expected number of oocytes, means from number of follicles, and you can decide. And it says that if you use dual trigger, it gives you higher number of oocytes, M2 oocytes also. Total number of blastocysts will be higher. Clinical pregnancy rate will be significantly higher, and live birth rate also will be significantly higher. Ashutosh sir. Okay, so you can go for a dual trigger. Ovulation trigger in poor responder again said that you must give a dual trigger every time, because it is associated with a better outcome in poor responders compared to single SCG trigger. So to friends, to summarize, ovarian stimulation is applied in the clinic to restore monoovulatory cycles in anovulatory women. But in IVF, we want multiple dominant follicles for multiple eggs retrieval. So it is the endocrine and follicular reaction of the ovaries to the stimulation that is called ovarian response. Achieving an appropriate response with the gonadotropins is the key part of your ovulation induction protocol. However, achieving an adequate response without cycle cancellation or having adverse effects like under or overstimulation is basically complicated, because there is a intra and inter individual variability, and that is why you need to choose your protocols. You cannot apply one protocol for all or single same gonadotropin dose for all. You need to vary according to the situation. Individualized ovarian stimulation is mandatory to solve these problems. So probably we need to choose our down regulation protocol. So success is no accident. It is a hard work, perseverance, learning, studying, sacrifice, and most of all, love what you are doing or learning to do is what makes you successful. So thank you very much, friends. And I hope that the concept of stimulation, especially, where to use which gonadotropins, what dose, how to plan your cycle, which scenario you will plan, which protocols. I think I'm clear. But if there are any questions, I will happy to take those lecture questions. So please shoot if you have. I think we have in chat some questions about low volume. I don't know what low volume means. Comment on Lupret 2 milligram of decapeptyl 0.2. I think that I already told if you have missed it. That is that dose you will use it as a GnRH agonist trigger. So that is something which is ideally recommended. I said in the first part of my presentation that whenever you want to use Lupret as a trigger, use 2 milligram. So you will aspirate from that luprolide 4 preparation. From 4 ml, you will take 2 ml and give that as a subcutaneously. And if it is decapeptyl, it is the 2 prefilled syringe you will use. Adjuvants clomiphene versus letrozole in poor responders. I think the more advantage has been with letrozole, and clomiphene is something which may have. See, in poor responders, we are planning a fresh transfer always. We don't want clomiphene induced thin endometrium in this patient. So clomiphene has got advantage over clomiphene for that matter. Then E2 per follicle. Yes, I think that's a very important question. So what you should do is on the day of trigger, you can send a E2. So one follicle normally produces E2 between 150 to 200. So you can easily judge. So for example, if you say that one follicle is equal to 200 E2, if you have 1000 E2, you will expect 5 oocytes. If you have 2000 E2, you will expect 10 oocytes. If you have 4000 E2, you will expect 20 oocytes. So that's how you can correlate. But for that matter, your estrogen assessment lab, estrogen measuring lab has to have a very standard and very robust protocol to assess, because estrogen levels are very fluctuating between labs. So choose your labs better. So I think if there are any questions, you can unmute yourself and ask me. I will answer it.
Sir, I think there are no questions. And
Sir, I have one question.
Yes, Ranjana, please.
Sir, you said regarding first that do a stim fresh. When, like you said, we can start the stimulation on day 18 or 21, suppose.
Yes.
Sir, what if we see a corpus luteum that time?
Doesn't matter. It
Still, we
doesn't
can go
interfere
ahead.
into your, because that corpus luteum is going to produce only progesterone. It is going to benefit you anyway because it will downregulate pituitary. You continue doing stimulation.
Okay.
Corpus luteum do not interfere into your ovarian response to your gonadotropins. It will, in fact, corpus luteum always produce progesterone, and like PPS protocol. If you have progesterone in your circulation, it is going to downregulate your pituitary. So it is going to be beneficial.
Okay, sir. Thank you.
Hello, sir.
Yes, please, Dr.
Yeah.
Surya. Yes, please.
You talk about that you have to give GNR agonist as a trigger in hyperresponders.
Yes.
In that case, you just say that you have to give 2 milligram on single day, or it
Yes.
has to be given 2 milligram on one day and 2 milligram on second day.
No.
Only.
I think that is been never tested and recommended. Remember, okay? Maximum 6-hour distance you can keep between if you are using a dual trigger. Otherwise, 2 milligram today and 2 milligram after 24 hours is not something which is recurrent. Now, the logic behind is very simple. When you give GnRH agonist as a trigger, one dose, the estrogen peak level goes within 6 to 8 hours and it falls down at the end of 14 hours. Okay, so remember that's how the LS surge happens when you give a GnRH agonist. So at the end of 14 hours, the LH levels will come down, and that's why it is very important that the LS surge has happened, giving another dose will not have any impact on your LS surge.
Okay,
Understood?
got it.
Yeah,
Thank you.
Sir, I want to ask one question.
please.
Sir, in IUI cycle, suppose there are more than four follicles,
Okay.
and I don't want
I lost your.
that cycle. So, what will be the trigger?
I
Either
lost your
HC.
voice. You said more than 4 follicles. You want to avoid OHSS.
I want to avoid OHS, and I also don't want to lose that cycle.
Okay.
Ha. So,
Okay.
what will be the trigger?
Yes.
Uh, uh,
Yes. Now
uh,
remember, there are two complications with this more number of follicles, more than 4. One is that it will cause OHSS if you give SCG, and
yes.
second, it will cause multiple pregnancy. Okay, increase the
Yes.
chances of multiple pregnancy. So you can avoid giving SCG. It will prevent OHSS because GnRH agonist, if you give as a trigger, you will get ovulation. You will not get OHSS. So that advantage you have. But the problem with agonist only is that it causes early luteal phase defect. So here what will happen, the chances of pregnancy will go down further. In IUI, you have already, if it is a controlled ovarian hyperstimulation, your pregnancy rate is 17, 18. But if it is single monofollicular growth, your pregnancy rate is 8 to 10%. And if you give agonist as a only trigger, only agonist as a trigger, it will further reduce. So pregnancy rates drops down if you use agonist as a trigger. So what you need to tell patient in this case that I will use agonist trigger, but I need to give you more higher progesterone to avoid early pregnancy, early luteal phase defect. So sometimes those 4 to 5 days, after the agonist, you might have to give injectable progesterone so that your progesterone levels are above 30 in the circulation, which are expected and which will help you to have a successful implantation. But that injectable is the only problem. But in any case, even if you use agonist as a trigger, you won't be able to prevent that multiple pregnancy rate. That you have to explain the patient. So if the patient is ready, sir, it's fine if I get twins or if I get triplet, I will reduce one. I'm absolutely okay. Then you give agonist trigger. You give intramuscular progesterone for at least 5 to 6 days, along with your vaginal and natural vaginal progesterone capsules, along with dydrogesterone. So you give good progesterones in that first 4 to 5 days, where you have early luteal phase effect, and then later you can, kind of, you can give something called as a mid-luteal GnRH agonist, small doses of 0.5 milligram, 5 days later from the previous trigger, and one more dose after 3 to 4 days. So 2 doses you can give, so that you can give, you are actually, what you are doing, trying to do is a good luteal phase support. So there is no defect, there is no low progesterone. So you achieve better pregnancy rate. And if your
Oh,
patient is not ready, that I don't want that multiple pregnancy to happen, then in that case, don't give any trigger. Leave it and put the patient on letrozole, or you can give agonist, but put the patient on letrozole, and that anti-estrogenic effect will cause, kind of follicle to regress,
suppression.
and you will not have
Suppression.
HSS.
Okay. 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 Thank you, sir.
Sure. If there are no questions, I hope I tried my best, because I want all of you to super fine into this part, because this is something which is very easy to understand, not very difficult, not many deviations are there. If you understand the endocrinology part, I think your stimulation is going to be, perfectly as per your expectations. And there are certain situations where you need to modify your stimulation protocol, and that with that you gain little more extra oocytes and better embryos. So uh, even please do not hesitate. If you have any questions, put it in the group. I will answer it to your questions. If you have any clinical scenario which you need help to fine tune the protocol, please don't hesitate and get back to me. I'm very happy to help you out in that. So with that note,
Sir, I have one more question, sir, please.
yes, Ranjana, please go ahead.
So like this is not related to IVF, but many a times when we do day 2 scans, and we have been already seeing the patients previously in previous cycles, and day 2 or day 3 scans when we do, we sometimes see the endometrium is also thin, but it's very secretory types. It's very hyperechoic, and there is a cyst.
Okay.
The on either side of the ovary, sometimes most of the times there is a cyst, sir. Even though the previous cycle the follicle had ruptured.
Right.
So
Now,
what should we do?
if I'm not worried about that cyst, but I'm concerned about that thick endometrium. So when you see on second day, patient tells you that I got my menses. Second day, when you scan the patient, what do you expect? You expect with a good withdrawal, all the endometrium to be shed off. So you expect thin endometrium. So
Yeah.
if you see a thick endometrium, remember there is not a proper withdrawal in that case. Even if she is bleeding, please do not start stimulation on that day. You ask her to wait for 1 day or 2 days, ask her to come back. Then you will see the all endometrium is shed off. Means patient has not got a proper menses yet. If you have a thick endometrium, if patient will have a thin endometrium on day 2 if she has a proper withdrawal. So just wait for a day or two and then you again scan her. You will see when you see that endometrium is shed off completely, now it is thin, you are good to go for stimulation.
Okay. So that means, sir, we need to call her back again after like 2 days.
Yes, 1 or 2 days depending on her. Look at the amount of bleeding. If she has started good amount of bleeding, just wait for 24 hours. But if she just has a spotting and thick endometrium, you call her after 48 hours.
Okay, sir. Okay. And we need not worry about the cyst. Even if the endometrium has become thin, but the cyst is there, what do we do?
If endometrium is thin and if there is a cyst, it is a non-functional cyst. Do not worry, continue your stimulation. That presence of cyst will not have any impact on your ovarian response or ovarian
Okay.
stimulation.
Thank you, sir.
Sure. Okay. So with that, thank you very much for the patient hearing. And we'll continue our lecture series on every Wednesday. You will get to know about next lecture in by Monday or Tuesday. And please join us with large numbers and don't miss the lecture because they are going to be very beneficial every week. So thank you. And
Thank you
I
so
hope,
much, sir. Thank you so
yeah,
much for
yeah.
this insightful lecture. I hope everyone has gained knowledge from this and people will surely connect you. Thank you so much, sir. Thank you. Thank you,
Thank you.
everyone,
Bye-bye.
for being patient and joining.